So this is the study area, the state of Assam in northeast India, and it exemplifies this particular state, how human-elephant conflicts unfold amongst marginalized agricultural communities. Assam has nearly 20% of India's wild Asian elephants, with 5 major elephant reserves covering about 13% of the state's area. It has a dense human population of about 31 million people, the majority of whom are involved in agriculture, which accounts for 69% of its workforce. That's from the Census of India 2001. Yet Assam remains a poorly developed state. Its per capita income is 40% lower than the national average. Food grain production has been steadily declining over the past 5 years. It is also a flood-prone area. These factors place local rural communities at high risk from both natural disasters and human-wildlife conflict. Crop raiding by elephants is a major concern, with government-documented damage of crops by elephants averaging about $110,000 each year. In one extreme scenario of conflict, 4,000 villagers belonging to 900 families fled their villages and took shelter in relief camps set up by the government. As many as 19 out of the 27 districts in Assam are affected by conflict. And this is particularly severe in the Sonitpur and Golaghat districts, where the current research was conducted. Both districts have important elephant reserves that you can see in the map there, but high rates of deforestation have escalated human-elephant conflicts, resulting in over 100 human deaths in the past decade. Several ethnic communities are present in the area, the dominant social group comprising an Assami-speaking Hindu community. Now the 4 case studies which I hope to discuss, and a group discussion which is detailed in the next section, are based on clinical and ethnographic fieldwork conducted in Golaghat and Sonitpur districts. So those are 2 districts at both ends where the conflict is high. I'm a psychiatrist and medical anthropologist trained in India and in the UK. I did my psychiatry training in India and then repeated that in the UK. And then did my PhD in medical anthropology at UCL. And Man Barua, my colleague, who's a human geographer, is finishing his DPhil and looking at the political ecology of the conflict. And both of us are bilingual. We speak Hindi, English, Assamese and English, Man and myself. The first case study, which was identified, I'll come to that later, was identified in September 2010 during the course of field work by Man Barua. And this research focused on the political, his research was focusing on the political ecology of the human-elephant relationship. But this particular subject in case study 1 had developed severe mental health problems and consulted local mental health services following an elephant attack. Subsequently, his clinic case notes were tacked on by myself at the local mental health clinic and summarized as a psychiatric formulation, which you'll see on subsequent slides. And the ethnographic narrative was provided by Man Barua. The case studies 2, 3 and 4 were traced by myself from a list of elephant fatalities over the past 2 years, provided by the local wildlife conservationists. I met up with each of the subjects at their homes between August and December 2010 and carried a follow-up after 4 months with case study 2 and a repeat follow-up of all the cases last month when I went back to disseminate the findings of our study to them in the form of a local lay Assamese summary, as well as a local story of their suffering that we wanted to give back because they shared their imagination with us of their suffering. Following an assessment of their capacity to provide consent, all subjects were informally consulted by myself, consented. And so I conducted an initial psychiatric assessment and a clinical diagnosis. And this was followed by an in-depth ethnographic interview to elicit a cultural narrative of their suffering. The interviews lasted from about 1 to 8 hours over the course of several meetings. And where appropriate and based on clinical judgment, a decision to refer for further treatment was facilitated. So the data for the case studies is structured along 2 headings to make it possible to compare. The first is a psychiatric formulation and the second is an ethnographic narrative of each of the cases. Case studies 3 and 4 are contextualized and presented under one heading as the interviews were jointly conducted. All quotes were direct translations of the interviews and case notes, and because space and time here today limits unpacking of the individual studies, the emerging themes that I would pull up would come up in addressing the final section on looking at the ecology and the clinic. So let's move to case study 1. This is subsistence agriculture as opposed to the elephant who was on a tea estate, which is corporate agriculture. And this is the land that they have bought. 2 widows, Beena and Rupa, whose permission I had to take the slide, and whom I gave back a pack of these slides as well as local Assamese version of the paper. Beena there in the bottom was sitting there, extremely poor. It's a mud house, and she's brought out some betel nuts to serve to me as a ritual form of greeting. She has got her compensation and has bought that piece of land, but that land is being slowly sold off to pay for the health care of her children and education, as well as for treatment, which supposedly is free, but it isn't, and they have to spend. Rupa here on the right is still waiting for her compensation. When I met her this time, she has received her compensation. At that time she was waiting, it was 18 months since the elephant fatality, and it has a knock-on effect, those 18 months, on the families who are surviving, including the psychiatric morbidity that developed there. So these are the case studies. I'll put the slide up throughout so that you won't get confused when I start putting out these names, because they're complicated. Case studies 2 is complicated because that's an example of how the elephant attack and the fatality caused kinship rupture and conflicts, but also psychiatric morbidity. And there, in the first case, of course, this was, I'll talk to you more about it. Alcohol played a slightly different role than in case study 2. And 3 and 4 again, we had alcohol as mediating the conflict, but once again a different manner. I'll start with Ramu, who's the first case. And I'll start with his psychiatric formulation, like I said, and then the ethnographic narrative. The psychiatric formulation is as follows, and I tracked it down from the clinic here. This is the clinic notes. So it's a summary of that, essentially, but I'll come back to some important observations there. Ramu is a 26-year-old married daily laborer who attended the local mental health outpatient clinic with his mother. The following information was detailed in his case notes. He had developed an acute onset progressive illness that was precipitated when he was present at a truck accident where he was a helper. The notes recorded that he was, however, not much hurt 1 month ago. So the narrative begins with 1 month ago. The accident did not lead to any major injury, seizures, or loss of consciousness. His presenting symptoms, as reported by his mother, were mentioned in the notes as disorganized behavior of 3 weeks duration. This comprised, quote, poor sleep, wandering away from home at midnight, dressing and undressing repeatedly, micturating in front of others, suspicious towards his wife and others, self-muttering, spontaneous laughing and crying, and gesticulating in the air, unquote. There was no history of past medical or psychiatric illness. His family history was noted to be not significant. Ramu's premorbid personality was not documented. His drug and alcohol history concluded polysubstance abuse, including ganja, alcohol, and tobacco, for the past 3 to 5 years. There was no history of substance dependence. And on mental state examination, he was observed to be conscious, dirty, hyperactive, irritable, and suspicious. His affect was blunted. His speech revealed occasional irrelevant talk. Ironically, a sample to illustrate this was recorded in his case notes. Quote, there it's in Hindi, you might probably not be able to see that. It's in Hindi, मैं यहाँ पागल, मैं यहाँ पे नौकरी के लिए आया हूँ. So that's recorded as a sample, an indication that he is mentally unwell, that his speech is irrelevant. I'll come back to this idea about what he has said and how the clinic has reframed this as an indication of mental illness. He was oriented to time, place, and person. His judgment was impaired. Physical examination revealed no significant abnormality except for mild pallor. So there is a very accurate recording of weight, blood pressure, pulse, and physical examination findings. So the doctors are good at the physical part of it, but you can see the case of the clinic and how that's editing out local ecology. Clinic diagnosis of acute schizophrenia-like disorder, ICD-10, F23.2 that you see here on the left, the triangle, that's the doctor's code of putting in a diagnosis. So that's acute schizophrenia-like disorder, together with multiple drugs and other substance disorder, ICD-10 F19.5 code, was made by the clinic psychiatrist. Ramu was prescribed oral antipsychotic medication, olanzapine 20 milligrams daily, and some anti-Parkinsonian and tablets and multivitamins. The family was advised to attend follow-up after 4 weeks because you can only give 4 weeks of medication free. The family did attend. The patient and his mother attended the follow-up, and that's the follow-up visit recorded below. And that entry states that there is an improvement in his mental state with no fresh complaints. Significantly, the case record stated that Ramu's irrelevant talk continued, but with lesser intensity and frequency. Now is the ethnographic narratives. And this was collected by Mount Barua because he was at that time in the field. And my account here is a summary of the case notes that I tracked down in return for doing a workshop at the local mental health clinic on culture and anthropology, its impact on mental health. Ramu is a 26-year-old married truck driver from the Adivasi caste community. He lives in a kacha mud hut together with his wife, mother, and uncle and aunt. The family is landless, living at the edge of a corporate-owned tea estate. Without any cultivable land of their own, the family earns a living by working as temporary laborers in the adjacent estate. About a year ago, 3 crop-raiding elephants broke into their home at night, having already demolished 12 other huts in the area. The entire family managed to flee without being hurt. Unfortunately, a burning kerosene lamp fell over at the time of the elephant attack, and their hut caught fire. In a few moments, the family home, together with all their possessions, including clothes, utensils, savings, and most significantly, Ramu's paper truck driving license were burned down. And for those of you who have done field work in India, you know what that means when you lose a paper truck driving license and how hard it is to get that back from the bureaucracies around. The family became homeless. They borrowed money from the community and from a private money lender at a steep interest rate to rebuild their hut. As temporary laborers, they were ineligible for compensation from the tea estate owners. The women in the family could not afford to buy new clothes and felt humiliated. Ramu's wife was pregnant at the time. As they were illiterate, of low caste origins, poor and unemployed, their social capital was extremely limited. They were unable to procure a government-sanctioned below poverty line card that would have helped secure loans. They were unsuccessful in their repeated attempts to obtain government compensation for the house damage. Ramu's father at that time was working as a day laborer in a neighboring state in Arunachal Pradesh and returned home with some cash reserves. The family persuaded Ramu's father to stay back, as a result of which he was unable to continue his former job. And this further stifled the family income. Based on a narrative retelling by Ramu's family members to Mount Barua, the incident deeply affected Ramu. In their words, he became mad after the event. Ramu stopped eating, went into fits of rage, attempted to destroy the family's rebuilt hut as well as their bicycle and tube well. He was unable to work as a truck driver as his paper license was burned during the elephant raid. Over time, Ramu became increasingly mute. On a few occasions, he attempted to throw his newborn child away. The family initially consulted a local healer, which is called a Oja, and borrowed money to pay for these consultations with no benefit. 3 months after the house burned down and following an accidental fall while loading a truck, Ramu's mother took him to the local mental health services where he was assessed in the outpatient clinic. He was diagnosed with a mental condition and prescribed medication. The family reported that Ramu showed a distinct improvement following the medication prescribed, and they attended a follow-up visit to the clinic. Now you can look at how the clinic reframes that, and there is a gaze which, both in spatial and temporal terms, shrinks the nature of the suffering to 1 week from the 4-month period. It also reframes the narrative, which actually has very important ecological antecedents, into an organic one because it begins with a fall from the truck and a head injury. So there is a shift from a cultural to an organic biomedical narrative. And this is where the gaze of the clinic in some ways edits out local ecology. We can discuss this later when we go further to look at this is another part of the story, which I think I won't go into it because is looking at the elephant trainers or the mahals, and they're drinking alcohol in order to tame the elephants, because they have to repeatedly keep the elephants into submission for a good few months every day. And there's a lot of ambivalence about doing that. But yet that's the only way for the elephant to finally accept the mahal as his master for the rest of his life. And it's fear that is induced with repeated beatings and whippings, which causes injuries. And the mahals, whilst their training period, drink huge amounts of vodka to cope with that. So that's another part of alcoholism landscape. Okay, so where are we time? I want to know whether I can skip case study 2. And maybe I'll skip case study 2 and go to 3 and 4, because 2 has a very complicated kinship network that is that's caused a rupture. But it's about, in brief, about a man who had a fight with his third wife in the field, at which time the food, the rice that they were carrying in the field, that fell over, and the pavilion on her forehead was wiped out. To her, that was a sign that she's going to be a widow. He then sulked and went away and slept in the local paddy field with a friend after drinking huge amounts of alcohol. He was attacked by elephants. A friend managed to escape. He was badly mauled and fatally injured. But at night, with no access to ambulances, police, jeeps or transport there, the family, that is his wife and his 11-year-old daughter, who's Smita Das, managed to wish their final goodbyes. And the daughter experienced severe trauma as a result, developed a severe school refusal and childhood depression. And even till now, she's in that state where she hasn't recovered. It's 2 years old. Because she saw this mangled body, had to wish him goodbye. And he would take her to school every day, bring her back, and buy sweets on the way. So there was a very strong bond. She still continues to ask for him, and where he is, and what has happened. The school knows about it, but are helpless in doing it. And then the family land was taken over by the deceased Praful Das's brother, who was Mukul Das. And that caused a huge rupture between Lakshmi Das and Mukul Das. So the relationship got strained, they separated out. It had an implication on their stepson, who was away, who started consuming huge amounts of alcohol. So that's in brief his story. But case study 3 and 4, Veena and Rupa, they were interviewed together. They were 2 young widows in their mid-20s whom you saw in the previous slide, who had lost their husbands to elephant attacks. Beena's husband Brahmin died 24 months ago, whilst Rupa's husband Dhiren had been killed 20 months prior to the interview. They were from the Kalvarta caste, that is a fishing community, displaced following erosion of their land by the Brahmaputra river. The village to which they had relocated was established after clearing forest land adjacent to an elephant reserve. Both families cultivated paddy for subsistence. Beena lived in a single-room mud hut with her 4 children. Her immediate neighbor Rupa also lived in a mud hut. Midway through the interview, 2 other elderly women, 6 young men, and 4 children of Beena and Rupa joined the discussion. As this interview took place in a naturalistic setting, it's difficult to frame it as a focus group discussion. The interview moved from a one-to-one dialogue to a wider discussion of social and economic problems that included human-elephant conflict, difficulties in accessing and paying for healthcare, experience of extreme poverty, and lack of support from the Forest Department officials. In order to examine the particularities that shaped the suffering of Beena and Rupa, I'm presenting their case formulation separately. So let me tell you the psychiatric formulation for Beena. Beena was a conscious and cooperative lady dressed in a white sari, a mark of widowhood. She looked anxious and worried. Her speech was normal. She had been experiencing symptoms of disturbed sleep, tiredness, and repeated flashbacks of elephants attacking her hut. Over the past 2 years, there have been several factual incidents when elephants had come into their village. Beena often heard voices of imaginary people chasing elephants during the day, but shrugged them off as her own imagination. At night, she was fearful of sounds and at times raised false alarms, held her children together, lying still on the floor, fearing that an elephant may be about to break into their home. Beena experienced nightmares in which she visualized elephants attacking her hut and her children. She also expressed worries about their health, as Beena's youngest child was retarded in physical growth and had severe scabies. A clinical diagnosis of post-traumatic stress disorder with depressive features was made. A physical examinations were not carried out. Now the ethnographic narrative. Bina's husband Raman was a qualified engineer. He used to work in the public government service in an urban part of Assam. Several years ago, according to Bina, when he was at his job, quote, his associates took money and played black magic on him. They set his gamosa, which is his towel, afloat the local river. After that, he became like mad when he went to the office. If someone forcefully took him to the office, he would leave his papers and run away, unquote. He lost his job. Raman never consulted nor was seen by any mental health professional. He often went missing for several days at a time. Several years later, Raman ended up working as a rickshaw driver, which he peddled for a living until the fateful night when he did not return home. Bina was not concerned at first, as Raman would often drink and not return home. However, that night she got worried. After raising concerns, the villagers launched a search party. Raman was found dead in a trench, ironically dug to keep elephants out of the village. His body was terribly mauled. A postmortem report concluded he had been trampled by an elephant. Bina explained that Raman's death was a result of his fate. She suggested that the elephant could have killed anyone else that night. Despite direct questioning, Bina did not think elephants were to blame. She expressed anger at the local politicians and government forest officials for not doing more to help. With 4 children to look after, Bina took up a job as a daily manual worker in the paddy fields. Her youngest child developed a health problem for which she had to get paid to get medicines. This situation aggravated her poverty. She said, quote, I have 4 children to feed and clothe. I haven't got land. From that land you cannot eat. Without goats or cows, you can understand under what conditions this house runs, and thus we so exist. I have no mother, no father. There is no brother, younger or elder. I have 5 sisters. I am the youngest, unquote. She subsequently spent a considerable amount of money towards her son's health care, mortgaging the small paddy land bought from the compensation provided by the forest department of about £400 towards her husband's death. She could not work long hours as her children attended the local government primary school and returned home early afternoon. Her eldest son, aged 15, had started odd manual jobs to prop up the family income. Bina was aware of local government health facilities. However, she would not attend as this entailed long queues, prescription costs, and threats of losing her temporary manual job. Bina told us that on one occasion she paid about £2.50 for 2 tablets prescribed for her child's illness. She did not think this was useful as she had little money to feed herself and her children. Further, she expressed a general frustration with the cost of healthcare. Quote, this boy, I showed him for weakness, and his head used to spin and he falls, and blood comes out of his nose. After showing all that, I bought 200 rupees of medicine. They only gave 2 tablets, unquote. When specifically asked about health seeking for her own psychological problems, she continued to discuss socio-economic issues relating to the healthcare. Quote, government hospital is there. Say we go, but the doctors don't see us for nothing. We'll have to buy a 5 rupee ticket, which is about 6 pence. Even without a ticket to travel, that 5 rupees will be required. Then a 10 rupees, that is 13 pence, bus fare will be required. And then medicines and all that, for which the doctor will prescribe medicines. He will tell us to buy the medicines from the pharmacy. How will it be suitable for us to go? The doctor, he examines and will prescribe medicines to be procured from the pharmacy. We need to go to the subdivision hospital. And once we go, we have to pay the driver and handyman, even if we do not buy the ticket. And as soon as we return home, the children will come and say, Ma has come. For them also I must bring something in hand. Even the pipe for the saline had to be bought. Quote, unquote. Now I talk about Rupa. Rupa's psychiatric formulation is very brief. On clinical assessment, Rupa came across as a sad young lady dressed in white, which marked her widowhood. She made good eye contact and was more vocal than Bina in expressing her distress. She reported sleep difficulties, dizziness and flashbacks of events centering around her husband's death. She had numerous sleepwalking episodes. On such occasions, she hurt her head running into walls at night. She expressed hopelessness over her future and humiliation at her condition. Quote, is there any worth in living? Live not for our own purpose, instead of being displayed and arranged like rabbits. It is better to die. It seems that we are just occupying space, unquote. On further probing, Rupa said she would not kill herself as it was her duty to look after her children. She regularly experienced panic attacks in the form of palpitations, dizzy spells, and a sense of foreboding. Rupa revealed a depressed mood that preceded her flashbacks. A clinical diagnosis of dysthymia, or depression as we call it, was made. A physical examination was not conducted, although she did not appear physically ill or malnourished. Now her ethnographic narrative. Rupa's husband Dhiren was killed in a tongi, which is the hut in the paddy fields where you have to be there to crop guard. In the paddy fields whilst guarding his crops from elephants at night. Following his death, Rupa spent a considerable amount of time to get documentation to claim government compensation. This included a post-mortem report and residency certificates. The compensation was still being processed at the time of this interview. She worked at a local stone quarry as a temporary labourer. She could only work limited hours as she had 2 young sons and needed to be home when they returned from school. Following Dhiren's death, with no other source of financial support, Rupa was living in severe poverty. She said at the time of her husband's death, the forest officials gave her a small amount of money to conduct Dhiren's last funeral rites and 10 kilograms of rice to feed the family. Since then, numerous journalists from the local press and foreign journalists and forest officials had visited, taken photographs and asked her many questions. Frustrated at the delay, Rupa, together with 30 other women, petitioned the local elected member of the state legislative assembly. He directed them to meet the forest officials. The forest officials in turn reassured Rupa that her claim would be processed. To date, she had not heard any further. This was the time we wrote the paper. She repeatedly talked about not having a man in her home, the financial consequences of her widowhood, and her illiterate identity that made it difficult to engage with more formal bureaucratic procedures for claiming compensation. Now, the men who joined in as the interviews were being conducted, I put that as a group discussion, but there's something interesting that has come up. An extended group discussion ensued when other neighbors joined Beena and Rupa. The discussion touched on concerns about the elephant menace, their poverty-stricken condition, the insensitivity of visiting government officials, and their own future predicament. When specifically asked what made them feel unsafe, the group mentioned the lack of electricity, non-availability of torches, and the absence of forest guards to regularly patrol their villages and paddy fields. They said their village was originally land where elephants lived, and that these animals were displaced when people moved in. Both elephants and the people had, in their words, hungry stomachs, for which there seemed to be no clear solution. I quote them, "The elephant did not come to attack us. Elephant has come for his stomach, just like we do for our stomach." When asked why elephants threatened their village, Rupa said, "We are bothering them. We are disturbing them. We are staying in their place." Another elderly lady joined in, and she said, "Till we are alive, this will carry on. Till man will be man, animal will be animal. Till such time, this will carry on. Till we are alive, we must carry on like this. Human numbers will increase. You cannot take humans and put them somewhere. And elephants, you cannot chase and put them somewhere." Later, when discussing personal hardships, an elderly woman said, "We think having given birth to children in our life, there has been no happiness, isn't it? In our life, will there be happiness? Happiness will not come. But these children that we have given birth to, we should be there to guard. With the difficulty, we gave birth to them. Raising them is our duty. To help them study 2 to 3 grades in school, that is our duty. After they grow up, whether they feed us or not is up to them." Unquote. Young men who were relatives of Beena and Rupa talked about the daily guarding of crops at night and consequent tiredness during the daytime. They looked tired and expressed several symptoms including fatigue, body aches and pain. They mentioned alcohol as one way of coping with this stress. The men seemed glad to share their problems and own views, but unanimous in expressing their daily hardship, including their fear, anger and frustration with their lives. So I'll finish off with a section which is entitled "The Elephant Vanishes," and we look at the ecology and the clinic. All of the case studies, including the case study 2, which I have in detail, suggest that both mental health and psychosocial dimensions of human-elephant conflict cannot simply be understood as a straightforward linear outcome of human-elephant encounters. We argue that the conflicts aggravate pre-existing problems such as poverty and mental poor health. Fatality from elephant attacks result in domino effects that multiply extant family conflicts and untreated mental disorders including alcoholism. They generate newer psychiatric morbidities and impact on maternal health. Further, explanations marshaled to understand human-elephant conflict by the study subjects are diverse and transitory, shaped by individual and social circumstances. In Ramu's case, It illustrates how such events stifle existing incomes, increase debts, and expose the poor and disenfranchised to newer spaces of institutional inequality. Both Ramu and his father's wage earning activities were severely hampered, the former because of the loss of his driving license, the latter for having to leave his job and return to rebuild the family home. And the clinic note that said, "I have come here for a job," is framed as an indication of irrelevant talk. Similarly, case studies 3 and 4, which is Beena and Rupa that I shared with you, show how subsequent poverty shifts burdens and additional responsibilities onto women. Both Beena and Rupa have to carry out manual labor in addition to providing childcare, leaving them exhausted with poor capacity to cope. In Praful Das's case, which I haven't mentioned, the complex role of property ownership and dispute as well as kinship strains emerge as a consequence of conflicts. And the elephant attacks bring about a rupture in the family relationships and stability as well as their subsequent health problems. Now, an important finding is the role of alcohol as a mediator in the human-elephant conflict. Alcohol seems to draw both humans and elephants together and lead to newer social and psychiatric pathologies. For humans, it has differential mediating effects as illustrated in 3 of the 4 case studies. In Ramu's case, the subject was known to abuse illicit substances including alcohol. It is unclear if his consumption increased after the elephant attack. That is Ramu, who went to the clinic. In Praful Das's case, he was drunk at the so-called illicit liquor distillery following a marital row just prior to the attack. In Beena's case, her husband appears to have suffered from severe untreated mental disorder. He was a qualified engineer at one time. The deterioration of his mental functioning is likely to have predisposed him to alcohol abuse. And we hypothesize that the immediate causes of deaths in case study 2, Praful Das and Beena's husband, the engineer, following an encounter with elephants, may have resulted from impaired judgment due to alcohol intoxication. Finally, the group discussion and Mount Barua's ethnographic fieldwork suggests that men often resort to alcohol to cope with added stress that crop guarding poses. Farmers do intensive labor during the daytime, and loss of sleep due to guarding fields at night leads to considerable stress. As a consequence, alcohol consumption is both heavy and frequent. Moreover, several farmers reported that alcohol gave them the courage to chase elephants, an activity that is dangerous and involves taking considerable risks. So that's the chart at the end of the picture. It's a very schematic, simplistic description. So far, agency in human-elephant conflict has been attributed to humans and to a lesser extent elephants. This is in contrast to the present study findings, which suggest that alcohol has agency in influencing these interactions. Alcohol enters these local political ecologies and binds people and elephants together in unforeseen and complex ways. This study does not establish a firm causal link between human-elephant conflict and substance abuse, but substantiates the relationship between alcohol consumption and crop guarding. And this relationship is symmetrical, as elephants are also drawn into villages because of alcohol, where they break into so-called illicit village distilleries. The agency of alcohol was indeed noted by the World Wide Fund for Nature, a conservation NGO, the WWF as it is abbreviated, working on human-elephant conflict mitigation in and around the study districts. They printed 2 posters which stated that people should stop brewing alcohol at home or wander alone in the dark after drinking, as they would be vulnerable to elephant attacks. Such locally rooted and organic observations of the problem could have been enhanced by adding information for help with alcoholism. This may be achieved by conservationists collaborating with mental health services to provide culturally sensitive substance abuse interventions. The other side, the flip side of the coin, accessing health care that is locally relevant and culturally sensitive has been argued to be the cornerstone of mental health care in low-income countries, right from the World Bank report which De Jallis and Kleiman and Benson produced in the late 1990s. Both international and national policies argue for service provision and care to move away from mental hospitals to the community. Most national health programs and policies include templates that echo this insight. However, as the case studies presented illustrate, they stop short of making explicit how this should be clinically operationalized in more concrete terms that are particular to local geographies. For example, in Ramu's case, the family obtained a small loan at a high interest rate to travel to the nearest mental health clinic, following unproductive consultations with local healers. In the second case, where I had intervened, despite intervention, the family did not attend the local services due to the stigma associated and the impact on the daughter's marriage. Ramu and Beena and Rupa's case show that many may not construe their problems as a mental health concern. In fact, they had access to a local primary healthcare team that visited the village nearby. However, they explained these clinics had long queues and required spending an entire day for medical consultation. In addition, payments for medication and travel costs further prohibited utilization of healthcare, despite India's stated national mental health policy of free treatment and care for its citizens. These issues strike at the very heart of India's mental health policy and training, and indeed the current global mental health movement. A conflict akin to that between elephants and humans for territory, home, and food is also played out in the interactions that take place in a sanitized clinic. For example, in Ramu's case, the reframing of his narrative into a psychiatric formulation edits out the ecological landscape, including important stressful circumstances such as poverty, loss of occupation, and his home destroyed by elephants. In addition, by selecting out the accidental fall from his truck as a precipitating factor and detailing a range of substance abuse, the clinic reframes a suffering initiated by human-elephant conflict into an organic biomedical narrative. Such clinical reformulations both justify and legitimize subsequent biological set of antecedents that are considered causal to Ramu's illness. In an earlier paper, we have demonstrated that pills at the clinic are the sole exchanges between rural Indians and clinicians at primary healthcare centers. Clinicians are trained to acquire a lens that systematically marginalizes local moral and social concerns of their patients. This results in a clean fit with Western-derived theory and classification at the cost of excluding local ecological stressors. One might argue that such a selective extraction of patient experience establishes and reifies a sanitized clinical gaze. As a consequence, the elephant vanishes. That's the title of the paper, inspired by those of you who are familiar with Haruki Murakumi's short story called The Elephant Vanishes. And I'd like to thank, really at the end, the study subjects who shared their imagination and stories. And in Assam, Jatin, Tamali, Nekib, Adupam, Dhruba, Alexandra, and the Assam Pati project facilitated fieldwork. Dr. Deary is the director of the local mental hospital for his assistance in accessing case notes. Man Barra transcribed the interviews and checked the translations. And we have also been grateful for Man's funding, supported by the Clarendon Fund and the Felix and Wingate Scholarship, and the grant from the Elephant family. And to the anonymous reviewers who helped us shape the paper further when we submitted in Health and Place, which was where it has been published recently. So I'll stop there because there's a lot more I could have gone on to look at and examine how we can perhaps connect ecology, culture, and the clinic, and argue for an interdisciplinary area where conservationists and mental health professionals in this particular context could collaborate and talk to each other, including implications for training on the ground, but also its implications for policy, both for mental health and for conservation. At a time when people are stuck with the conflict and do not know what to do except for putting electric wires and trenches, and people who are in this situation where they're caught and nowhere to go. And the elephant is a huge resource in the West. It's a multi-million-pound industry, and it's seen as a very nice, cuddly, exotic animal that has to be preserved at all costs. And those of you who are familiar, in London there was an elephant parade 2 years ago where there were elephants all around the city of London, put down by major artists. They were auctioned off later on and generated millions of pounds.
Fascinating. Thank you.
Thank you.
Very much.
Thank you for your